there, my name's Elise DeVore-Berlin, and I'm excited to give you a talk right now on polycystic ovary syndrome update, diagnosis, and management. I do have some disclosures, feel free to review, and I will discuss off-label use of medications. And the learning objectives are here. For this talk today, I want to talk to you about treating a condition known as polycystic ovary syndrome. And I actually love to treat this condition, and I hope that I can communicate to you the real advantages to being familiar with the treatment and the diagnosis of polycystic ovary syndrome, because I think you'll make a big difference for your patients. During this talk, we're going to address four topics. The first is the special challenges in diagnosing PCOS in adolescents. The number two is the clinical features of PCOS in adolescents. 3, evaluation for PCOS, and 4, treatment of PCOS in adolescents. And I'm going to do my best to stick to the quite short timeline that we have. So please keep track of questions, comments you have, and I look forward to discussing them with you at the live Q&A. I have a case for us to consider in our minds as we review the first third of the slides, and then we're going to bring her back towards the middle of the presentation. So just to center us, we are seeing a 15-year-old who presents to the office with concerns for oligomenorrhea and hirsutism. Her menarche was at age 12, and she has periods every 3 to 4 months. She has noticed increased hirsutism on her chin and sideburn areas over the past 2 years. And she has always struggled with her weight, and her mother has polycystic ovary syndrome. All right, well, let's get into it. Polycystic ovary syndrome is also known as PCOS, and it affects about 4 to 6% of adolescent girls and young women. I really do think about PCOS as a developmental condition that presents not infrequently during adolescence, and then manifests more and differently as women get older throughout their reproductive life and their lifespan. In one clinic among adolescents presenting with oligomenorrhea or infrequent periods, slightly more than half actually met criteria for PCOS. So I suspect as general pediatric providers, you are very likely to see and care for young people with this condition. And in fact, it is the most common endocrinopathy in reproductive age women, affecting 8 to 13% of women. So, why the attention on PCOS? So, for young people, the physical symptoms of PCOS can be extremely distressing. The kind of stereotypical phenotypic symptoms are moderate to severe acne and hirsutism, which is excessive facial and or body hair. And as you can imagine, these can really impact a young person's self-esteem and quality of life. There are increased risks for long-term health concerns among young people with PCOS, so identification is important. Perimenarchal presentation is common. There are even patients that I've seen and in the literature who present as primary amenorrhea. So you may have younger patients who have this condition than you are used to thinking about. Part of the challenge with adolescents and PCOS is some of the symptoms and signs of PCOS may be confused with normal development in adolescents, and it can be difficult to distinguish between the two. As well, diagnosis and the treatment approach in adolescence has been quite controversial, and there still are some controversies. When I talk to my patients about where does this come from, why do they have it, I do not have a good answer. I say this is likely multifactorial and has been influenced by genetics as well as the environment and the person's own lifestyle as well. There are all kinds of heritability, genetic and epigenetic factors that are being characterized and are off topic for this talk, but the science is moving forward. And really, PCOS is now recognized not necessarily as primarily a gynecologic disorder, but as an insulin-resistant and metabolic disorder. So we're going to talk about that. The pathophysiology of PCOS is evident at multiple system levels in the body. And when we think about the hypothalamic pituitary gonadal axis, as well as the adrenal hypothalamic pituitary system, there are marked abnormalities in all of those levels. To start with, at the level of the hypothalamus, increased pulse frequency of the GnRH pulse generator favors pituitary LH secretion over FSH secretion. And the impact of that is that exaggerated LH pulse frequency and amplitude from the pituitary then actually favors ovarian androgen production over estrogen production. Usually in these patients, FSH levels are low to normal, but you can see the whole HPO system in women with PCOS does favor androgen production. At the level of the ovary, 60 to 80% of women with PCOS have elevated testosterone levels, and most of them demonstrating increased free testosterone. And what is happening at the level of the ovary is that ovarian fecal cells are secreting excess androgens, which include both androstenedione and testosterone, under basal and LH stimulation. It's not well understood exactly why this is happening, but there's a dysregulation of steroidogenesis that is suspected. And then high intra-ovarian androgen levels and low FSH levels impair follicular maturation and estradiol production, essentially getting in the way of having ovulatory cycles. And there is a minority of women, and I have many patients who have demonstrated adrenal hyperandrogenemia. In the literature, about 25% of women with PCOS have elevated DHEAS, which is primarily an adrenal androgen. And in women with PCOS, ACTH stimulates slightly abnormal increases in adrenal androgens. And again, it's not well understood, but dysregulation of steroidogenesis is suspected. This is a slide that shows a model of how obesity through insulin impacts ovarian and androgen adrenal hormone production. So starting at the top of this slide, we start with increased adiposity, in particular visceral adiposity. This adiposity promotes elevated insulin levels, and the insulin levels lead to varied actions in the body, including decreased sex hormone binding globulin synthesis in the liver, increased cytochrome P450 activity in the ovary and the adrenal gland, and increased sensitivity to GnRH in the pituitary, which all kind of feed forward and feed back to lead to increase in circulating androgens. And then the androgens can kind of feed back to the top of that loop by contributing to visceral adiposity. So we really have a complex scenario where obesity, insulin resistance, and sensitivity, as well as adrenal and ovarian androgens are interacting to create the condition that we call polycystic ovary syndrome. So let's start with making the diagnosis. The most current guidelines were established in 2018 by a very, very large consensus panel in representation from all over the world. So I think these are really the best, most current contemporary guidelines. They're called the International Evidence-Based Guideline for Assessment and Management of PCOS 2018. The website is linked in my slides, and I recommend that you familiarize yourself with it if you'd like to learn more. So the definition of PCOS for adolescents is within 8 years of menarche, there is ovulatory dysfunction as well as clinical or biochemical hyperandrogenism, plus exclusion of other disorders. Important for you all to know is that ultrasound is not recommended for the current diagnosis of PCOS in adolescent patients. So essentially, an adolescent to meet the criteria for this condition would have ovulatory dysfunction, as well as either clinical or biochemical hyperandrogenism, as well as exclusion of other disorders. And we're going to go through these step by step. So let's talk about menstrual dysfunction first. The best place to start is really centering ourselves on what is normal menstrual function. According to these guidelines, the first year of menarche is more or less an anything goes with regards to PCOS diagnosis. They don't establish a criterion within the first year post-menarche. However, during the first 2 years of menarche up to the third year, menstrual cycles that are less than 21 days or more than 45 days are considered irregular. After the third year post-menarche to perimenopause, cycles less than 21 or greater than 35 days or less than 8 cycles per year are considered irregular. As well, after the first year post-menarche, more than 90 days interval for any one cycle is considered irregular. And then always we think about, for pediatrics patients, primary amenorrhea by age 15 or more than 3 years post-thelarche or breast development is also a concern for menstrual irregularity and can be considered a criteria for PCOS. However, these are the challenges with adolescence, right? So physiologic anovulation may persist for many girls for 1 to 3 years after onset of their periods. So you're often seeing girls with irregular periods. However, most girls will have a regular period by 1 year. So that's important to keep in mind. Irregular bleeding patterns related to PCOS and physiologic anovulation related to hypothalamic immaturity can be indistinguishable. However, going back to the guidelines, they do state that when irregular menstrual cycles are present, a diagnosis of PCOS should be considered and assessed according to the guidelines. So it's important to keep it in mind, even when you aren't certain. So number 2, we've talked about the menstrual irregularity and the criterion. For hyperandrogenism, we'll go over what that looks like. So clinical hyperandrogenism is present in most adolescents with PCOS, and they may present with hirsutism, which is dark, coarse hair on their face, back, chest, abdomen, or thighs. I'm going to show you what the screening looks like using the Ferriman-Galloway score, or scale, excuse me, and a score of more than 4 to 6 can be considered hirsutism in an adolescent. Also, inflammatory or cystic acne in particular that's resistant to treatment is also part of the clinical presentation of clinical hyperandrogenism. Some young people do present with male pattern baldness or thinning, but that's not currently a diagnostic criteria. This is an image of hyperandrogenism and hirsutism in a female. You can see some kind of dark, still on the finer side, but long hair on the chin line, under the chin and on the chin in this image. A lot of young people are very sensitive about their body hair, and it's important to be quite thoughtful when you talk to them about these symptoms. I sometimes ask, do you have any concerns about your skin, such as acne or excessive facial or body hair? I might follow that up or ask a separate question with, do you use anything to remove facial or body hair? And then when they specify what it is, I might ask how frequently they do that. Using physical exam alone isn't recommended because young people can be really good at kind of treating and removing body hair. This is an image of a young woman with kind of male pattern body hair in the lower abdomen and lower back. And this is a image of the modified Ferriman-Galloway scoring score for hirsutism. In adult women, the score greater than 8 indicates hirsutism. but we've talked about using a lower score and a lower threshold for adolescents. You can see this is something that you can pull up on Google, have a handy document in your office, and it really goes through face, chest, back, genitals, such as pubic hair distribution, and buttocks, and then you score each area from 1 to 4, and then add them up, and that gives your total score. So it's recommended that a calculated free testosterone, free androgen index, or calculated bioavailable testosterone should be used to assess biochemical hyperandrogenism in the diagnosis of PCOS. And ideally, you want to use a lab that's using a high-quality assay, such as liquid chromatography, mass spec, or mass spectrometry and extraction chromatography immunoassays. These are the best tests for the assessment of total and free testosterone. The assessment of biochemical hyperandrogenism is most useful in establishing the diagnosis or the phenotype for adult women where signs, clinical signs of hyperandrogenism, in particular hirsutism, are unclear or absent. I would say in pediatric practice, it's most common to get these labs in all patients that you are considering PCOS, but keep in mind that they are not required, that clinical hyperandrogenism can be evidence enough. The interpretation of the lab test should be guided by the reference ranges of the laboratory that you use, not by external reference ranges. And really think about if the androgen levels are markedly above laboratory reference range, other causes of biochemical hyperandrogenism need to be considered. And we'll go over some of those differentials in a few slides. But just as we talked about for menstrual irregularities, adolescence ushers on many changes in skin and in hair development, and it can be a bit of a challenge sometimes to distinguish normal versus pathological. In particular, acne commonly develops during puberty, and also identification of hirsutism can be difficult for a variety of reasons, but among those, it could just be a heightened sensitivity to the development of normal body hair and kind of physiologic changes of adrenarche. However, even modest evidence of increased hair growth, especially in early adolescence, and persistent progressive hair growth associated with irregular periods should be evaluated and considered an evidence of excess androgen production. Features of PCOS. All right. So let's just go along and talk about some associated features that not all patients have, but are common. So obesity often begins in childhood, as you know, and worsens during adolescence for most obese children. The majority of adolescents with PCOS are overweight or obese, but there are lean women with PCOS, and even among lean women with PCOS, they have decreased lean body mass, increased body fat composition, and increased abdominal fat and central adiposity compared to their non-PCOS controls. So even lean with PCOS do have some alterations in their body composition. We talked about this on an earlier slide, but obesity absolutely can amplify the abnormalities associated with polycystic ovary syndrome. We talked about how obesity contributes to insulin production, and you know it contributes to insulin resistance as well. In studies of girls, they have found that central adiposity correlates with androgen levels. And as we discussed, obesity is negatively related to sex hormone binding globulin, which increases androgen bioavailability. Another feature common among women and girls with PCOS is insulin resistance. We definitely see insulin resistance present in both lean and obese adolescents. And some studies have found up to 1/3 of both lean and obese have abnormal glucose tolerance. Part of the reason I like treating PCOS is because the impact is so broad, and the ability to really improve quality of life is present by thinking through and counseling your patients about the associated health risks. So when I first make the diagnosis, I do talk about these health risks, and I put them in a lifespan framework, but they are important for your patients to know about. And I do think it's important that they hear about them from you and not from Dr. Google or WebMD. Women with PCOS, as you may know, have fertility issues related to anovulation. They are at higher risk of having pregnancy complications, such as gestational diabetes, preterm delivery, and preeclampsia. They have increased risks for endometrial hyperplasia and endometrial cancer. They also have some additional health risks that I have become more familiar with over the last several years, but increased risks compared to their non-PCOS controls. Increased risk for sleep apnea, for depression, anxiety, for disordered eating and eating disorders, as well as poor quality of life. So above the risks of being overweight or obese, they are layered more for women with PCOS. So this is really a heavy diagnosis to put on somebody, and it's really important to have time to talk through all of this. And I talked about framing it within the course of a woman's life. I find this really, really helpful when I'm first talking to patients about the diagnosis. We talk about that during the earlier parts of a woman's life, that the most concerning characteristics of the condition are menstrual disorders, body hair, acne, contraception, sexual health, and fertility. Then I talk about how as they age, a variety of other conditions and risks may become more prevalent, such as risks around pregnancy, fertility, type 2 diabetes, cardiovascular disease, and cancer risk. So let's talk about how we make the diagnosis. We've touched briefly about the importance of using a high-quality hormone assay. The differential diagnosis I've separated here into more common and less common. So among young people coming to you with concerns for oligomenorrhea in particular, and or excessive body hair or acne, together you want to consider pregnancy as a cause. Obesity may be, at the end of the day, the only thing that you find. Certainly can be relative energy deficiency syndrome causing the anovulation, and I've had several patients where it's a little difficult to figure out what's happening, even among obese young people. Hyperprolactinemia, idiopathic hirsutism, as well as hypothyroid are all more common causes of either irregular periods and or the phenotypic concerns. Less common are Cushing's syndrome, acromegaly, an intersex disorder, hypertrichosis, which I call just plain hairy, late onset congenital adrenal hyperplasia, and an androgen secreting tumor. These are all things I recommend you keep in the back of your mind, but most important to exclude the common conditions in the differential. Like everything we do, we're starting with a history and exam. So the details of the menstrual history are important. Asking about unwanted facial or body hair, asking about acne and the any preceding or current treatments that they've used, either over the counter or prescription. How the symptoms have progressed can be helpful, and also reviewing height and weight trends, which we're quite adept at doing as pediatricians. The past medical history elements that I think are most important include whether the baby had LGA or IUGR, because this has been found to be a risk factor for some PCOS, obesity, migraine with aura, and that's relevant because you may think about treating them with a combination oral contraceptive pill later, and it's good to know your medical contraindications. As well, premature adrenarche also has an association with PCOS. I cannot overemphasize how important the psychosocial history is. As I've seen in my career, so many young people have an element of anovulation that is impacted by mental health, such as having problems with anxiety, depression, suicidality, stress, peer and family issues, and self-harm. So all of these psychosocial history elements can explain or partly explain menstrual irregularity. So it's important to be able to understand kind of what are the potential contributing factors for your patients. Lifestyle history is really good for you to know, including activity and exercise, both because these can contribute to anovulation if they are excessive. As well, they can serve as a good launching point for conversations about healthy lifestyle later. And nutrition habits are important as well, including restrictive eating and binging or purging. Please don't assume because your patient is obese or overweight that they do not have disordered eating or restrictive eating problems or even binge purge problems. Medications review is important, and then one of those real complete review of systems. Family medical history, I think, is important to look for potentially contributing conditions, including hirsutism or familiar hypertrichosis, so people who are very hairy in the family, menstrual and gynecologic problems, fertility problems, and also just inquiring about subfertility, cardiovascular disease, dyslipidemia, blood pressure, diabetes, and other endocrinopathies such as thyroid disease. So really getting a full sense of the review of systems, the past medical history, birth history, family history, growth charts. In the exam, focusing on vital signs, attention to weight, hypertension, BMI, evidence of androgen excess on exam, such as moderate to severe acne, the hirsutism that we've already talked about, hair loss on the head. You can sometimes see in some conditions on the differential, such as Cushing's, android fat distribution or buffalo hump, striae, which you can see just with rapid weight gain and or obesity. You want to check pubertal staging and breast development, as well as an external GU exam. And this isn't really just a kind of a quick peek at the top of the underwear. I do recommend doing a frog leg exam and getting a good sense whether the clitoris is virilized and if the vulva and the tissues are looking nice and moist, which indicates a normal estrogen status. The standard diagnostic labs at the time of that first clinic visit for this problem include prolactin, TSH, FSH, a pregnancy test, and then the androgens that are recommended include testosterone, free testosterone, sex hormone binding globulin, and DHEAS. Additional labs to consider include an 8 AM 17-hydroxyprogesterone, and this is to rule out late onset congenital adrenal hyperplasia. You may select to do this in all patients or in select patients such as if they had premature pubarchy, clitoromegaly, or have a high DHEAS. So some people choose to do this in all for their evaluation, and some do take a tiered approach and screen them if they have additional abnormalities by history, exam, or labs. So going back to our case, if you recall, on exam, and this to review the key details of the case, she was a middle adolescent who had markedly abnormal periods every 3 to 4 months with some concerns for body hair and acne by history. So on exam, her BMI is 33, she has a normal blood pressure, moderate acne, mild hirsutism on the chin and cheeks. She does have acanthosis nigricans at the back of her neck, some abdominal striae, and well estrogenized vulva without clitoromegaly. And as you review the labs that you requested, you see that she has a mildly elevated free and total testosterone, low sex hormone binding globulin, low normal FSH, and normal prolactin TSH, and a negative pregnancy test. The question is, what is the diagnosis? Is this PCOS? The answer is yes. She has had menstrual dysfunction for 3 years post-menarche, and she has biochemical hyperandrogenism with a mild clinical presentation. And we have sufficiently ruled out other common causes at this point. So just to review what the criterion are, within 8 years of menarche, ovulatory dysfunction, as well as clinical or biochemical hyperandrogenism, plus the exclusion of other disorders. And an ultrasound is not recommended as part of the standard evaluation. The next step of the evaluation that I recommend is continuing with lipids, ideally a fasting lipid panel, as well as assessing for glucose intolerance. There is some back and forth about what is the best screening for adolescents with PCOS for glucose intolerance or insulin resistance related issues. The current guidelines recommend in high-risk women with PCOS, which includes a BMI greater than 25, so probably going to be most of your patients with PCOS, and OGTT is recommended. The other criterion include Asians with a BMI greater than 23, a history of impaired fasting glucose, impaired glucose tolerance, a family history of diabetes type 2, hypertension, or high-risk ethnicity. So for me, this is really most of my patients with PCOS, and I have switched over the last year or so to doing OGTTs in all of these patients. So as a second round of labs after you've made the diagnosis, recommend doing these labs. And then if she is oligomenorrheic, then the next step is to do what we call a Provera challenge. This is going to be using medroxyprogesterone, 10 milligrams a day for 10 to 14 days. And this is going to bring on withdrawal bleed in people who have a sufficient physiologic estrogen levels. So both kind of a assessment of the outflow tract as well as a physiologic assay for estrogen. All right, moving forward with management. And I know we're getting towards the end, so I'm going to speed up. The slides will have all the details. This study by Maria Trent found that menstrual cycles and body hair were really the primary concerns of adolescent girls with PCOS. So I think that's really helpful to keep in mind and makes our job as pediatricians more focused on periods, skin, and body hair. The short-term treatment aims are to regulate the periods, to address the hirsutism, treat the acne, to discuss, although this is difficult to get in most cases, but to talk about a 5 to 10% healthy weight loss, to talk about at least 150 minutes per week of activity, and improved quality of life. The long-term aims are really to decrease a young person's risk for diabetes and cardiovascular sequelae, to protect their endometrium, to reduce the risk of endometrial hyperplasia and cancer, and to really do everything we can to protect their future fertility. So in terms of treatment options, we really start with lifestyle. So the first part of lifestyle I think about as kind of weight loss and exercise. And really, any activity is good activity. Activity and physical activity have an excellent side effect profile. There are numerous benefits on menstrual function, body composition, hyperandrogenism, and insulin resistance, and mood and stress. So just about everybody is going to benefit from a little bit more activity or exercise in their life. The main key is that it may prevent long-term cardiovascular events and the progression to diabetes. The dose, the ideal dose is high, and most of us probably do not get this, but for adolescents, the dose is more than 60 minutes of moderate to physical activity per day. But again, any activity is good activity, and you want to consider the role of allied health professionals such as PT, OT, and trainers. I think they're potentially some great allies for your patients. For nutrition, it's really back to the basics. Portion control, avoiding processed food, sugared beverages, limiting eating out. No single diet has demonstrated superiority for PCOS, and it's really important to be careful in your language about nutrition to avoid promoting disordered eating or body image problems in these patients who have an increased risk for disordered eating. So regarding nutrition, there is not a consistent messaging that's recommended. I think you're really going to want to customize this to your patient, whether you talk about a 5 to 10% weight loss goal or preventing excess weight gain. I go to both of them and back and forth, depending on the clinical scenario. These patients can certainly benefit from some motivational interviewing. Depending on the patient, they may want to be, or you might want to refer them to a comprehensive weight management program or a dietitian. And they certainly may benefit from getting more information about recreational opportunities and facilities in the community. Switching gears to talk about pharmacotherapy, combination oral contraceptive pills have been the mainstay of therapy and are really standard treatment. They reduce androgen levels, they increase sex hormone binding globulin, regulate periods, protect the endometrium, they treat hirsutism and acne. They kind of do everything phenotypically that we are looking for. However, the approach is symptomatic and it doesn't address the underlying insulin resistance. So I think that's really helpful for us to remember that exercise and lifestyle changes really are important to address the underlying insulin resistance and obesity issues. As a practice pearl, I tend to use a low-dose pill, such as Sprintec or orthocycline for my patients with PCOS. Metformin is being recommended more for young people and women with PCOS. The benefits of the use of metformin include lower androgen levels, improved ovulatory function, fertility induction, improved lipid profile, and insulin sensitivity increases. And then there have been some brief small studies in adolescents, and they have demonstrated multiple hormonal and metabolic benefits for adolescents with PCOS. It may not be ideal monotherapy for an adolescent. For one who's interested in avoiding an unintended pregnancy, clearly there are some issues there because it can induce ovulation and bring to the fore the issues around pregnancy. And it also is not demonstrated to be as good as combination oral contraceptive pills for control of androgen features. But it can be, and it should be offered to certain patients. Those might be those who do not want to use any hormones, or those who have metabolic risk factors, such as obesity, insulin resistance, impaired glucose tolerance, or strong family history of diabetes. The primary side effects of metformin are GI discomfort. It has not been demonstrated to cause hypoglycemia in normal circumstances, and lactic acidosis is rare in young, well-hydrated people. The initial dose is 500 milligrams daily, and it is titrated to a maximum dose of 2 grams per day over several months. And the extended release formulations can be easier for some people to tolerate. If you are prescribing metformin, it's important to counsel about taking it safely, so avoiding it if they're fasting, if they're ill, if they're having surgery, etc. It's not recommended if a patient has liver or renal impairment, so check liver function and UN creatinine before initiating. And you may consider advising a multivitamin and periodically monitoring a CBC for macrocytosis. I tend to use spironolactone more than metformin. This is an aldosterone antagonist with anti-androgen properties at the hair follicle level. It can be really helpful for hormone-sensitive acne as well as facial hair and body hair. The dose, most of us stay between 25 to 100, but there are 200 milligram doses that some people will use. And what I tell my patients is that it can decrease the growth of new terminal hair, and current terminal hair may become finer, but it will not kind of remove or eradicate those activated terminal hairs that are already dark. It works really well in conjunction with a combination oral contraceptive pill. There are some additional progestin-based treatments that you can use. These treatments don't have estrogen, so we lose the ability in these treatments to really rebalance the hormones. But these treatments can be useful for helping with menstrual either suppression or regularity and or preventing endometrial hyperplasia, as well as some of them are contraceptives. So I have some patients who take a cyclic or continuous oral progestin. I have patients with PCOS who choose to use Depo, Provera. I have patients as well who use a levonorgestrel intrauterine system or the etonogestrel implant. So I just wanted to widen your view that progestin-only contraceptives can be used to treat elements of PCOS, but they don't really get the whole hormone balance the way combination oral contraceptive pills do. And then you want to think about maybe considering metformin in these patients. for metabolic dysfunction. Follow-up visits I tend to do every 6 to 12 months. I recommend patient-centered management of reproductive, dermatologic, and metabolic issues. Screening for comorbid conditions is important to do. So depression, anxiety, disordered eating, and obstructive sleep apnea, we do screen every 6 to 12 months. And then periodically assess sexual activity and risk factors, and surveillance of the BMI and blood pressure. And periodically screen glucose tolerance and lipids. In my practice, I tend to do this every 2 years. And then providing written information to patients and families can be really helpful. Some practices use a standardized visit form or flowchart to capture these elements, and that also can be helpful depending on your practice. Here are some really nice patient-facing materials that are available. So the youngwomenshealth.org is from Boston Children's Hospital, and actually that is the materials that I use most of the time for my patients with PCOS. They've got excellent guidance about the condition, as well as treatments. They have chat groups, forums, etc. So I love to send my patients to youngwomenshealth.org for adolescent-focused information about PCOS. And there are some new resources. There's this Ask PCOS app that was made by the folks who published these guidelines at Monash University. And then there's also an online resource for women with PCOS called Ask PCOS, that's patient-facing. I tell my patients that they should use caution when searching for PCOS online because there's a lot of misinformation, and a lot of the information is targeted towards adults. So really, I think having some information about web resources or some print resources handy can be very useful. So that was a quick run through. I hope you feel more informed about the current diagnostic criteria. I hope you also feel comfortable understanding what are the hormonal treatments and some newer patient-facing educational materials. I look forward to talking with you at the Q&A, and also please feel free to email me with any questions. Thank you. Bye-bye.